Okay, here we go. Welcome everybody to Tuesday edition of VMR. I'm very excited to be here today. I was waiting for my co-discussant, but well, let's get things going as it's 11:05. And what we'll do at some point breakout rooms, and we'll discuss this case that Eugene has kindly prepared for us today. And before we get going, I'm going to ask Eugene to unmute and say hello, and then Samantha is going to be scribing, and Vale is going to be doing teaching points. So our fabulous team, without whom we can't do this, definitely would love them to just unmute and just speak a little bit about how the Tuesday's going. Go ahead, Eugene.
Yeah, hi everyone. My name is Eugene, medical officer from Ghana. And I got this case actually from someone started seeing from the ER, and then we were invited to continue to see. So it's a fascinating, rich internal medicine case, and I'm happy to share today with all of us.
Okay. And Samantha, how you been?
I'm good. I've been busy. I think like many of us working on um those applications, just trying to get it ready, but I have the best helper. So,
Amazing. What's your cat's name?
Cersei,
Earth.
like the witch. Yeah. She loves VMR, so
Awesome, awesome. And Samantha is applying for emergency medicine this year, so lots and lots of luck to you.
thank you.
And then we have Vale, who is applying for neurology. Very excited for your application this year.
Thank you, Ravi, and thank you so much for your support. Similarly to Samantha, I'm also in the midst of getting those last touches of the application ready. So really excited for the future, and yeah, happy to do teaching points today.
Awesome, wonderful. And let's launch the whiteboard and get going. Over to you, Eugene.
Yeah, okay. So the first I have about 5 or 6. So the first is just the presented complaint, which is a 65-year-old man presented with progressive exertional dyspnea, chest discomfort, and inability to walk long distances. The symptoms had been gradually worsening over the past 6 years, but within the last 2 weeks, it got worse, and he decided to come to the hospital for further management. I'll pause here for us to discuss.
Wow, very unusual, Eugene. So you have a patient here that's, you say, middle age. 65 years of age isn't like a 65-year-old patient maybe 10, 15 years ago. Definitely comorbidities will help us to sort of set the stage. Like, does this patient have history of coronary artery disease? Does the patient have certain risk factors that could actually make respiratory disease maybe likely for this patient? But not only do you have this chest discomfort, but you have this shortness of breath. But it's been going on for a long period of time. And then you have to start wondering about things that can cause shortness of breath over years and years and years. And what's interesting is suddenly in 2 weeks, it's brought the patient to the emergency room of the hospital. So going through conditions, when you consider chest pain and shortness of breath, you do an overlap and you think of before diagnosis systems. This has to be a overlap, maybe cardiac into the respiratory system or respiratory lungs into cardiac. So those are the two areas which I'm very concerned with. At this point, the inability to walk long distances can be interesting. What does that mean? Does it mean are the legs not getting fed blood? Is there an issue, oxygen not getting to the blood, and the heart not able to pump to the legs, and then you end up having like atrophy of the muscles just because of cardiac cachexia, things like that, that the legs aren't able to get the energy of life, which is blood, ATP, oxygen, to the legs to be able to move. And the legs have the largest muscle group in the body, right, as well. So they are highly energy requiring muscles, especially when you're ambulating, requires quite a bit of effort. Then I also have to think, is there something going on in the legs as well, which could also affect the upstream organs like the heart, so vascular disease. So when you're walking, Are you having issues with maybe blood supply? Is there peripheral artery disease, which can also impact? They always say peripheral artery disease can be a nominal sign of coronary artery disease. So vascular systems downstream can affect upstream systems as well. So you have to also wonder about this. But it's very interesting. 6 years been suffering with this, then all of a sudden, 2 weeks it's gone worse. You can't help but think about something else superimposing. So there's this background, and the patient's sort of been dealing with this for 6 years, but it hasn't really impacted what they're doing. We do want to know what his occupation is, what does he do, and then also think about in the last 2 weeks, how did this get worse? Did he do something? Was there something new that happened and maybe exacerbated this? So I think at this point, my focus will be on the cardiac pulmonary, but also I would look at the legs too to see if there's significant signs, like if there is peripheral artery disease, is there cyanosis, is there cold, are there arterial ulcers, and all of those things associated with peripheral artery disease. But I'll send it back over to you.
Yeah, so amazing thoughts, amazing discussion. So of course, when we get the presentation of shortness of breath and then chest discomfort, the schema usually goes along the same pathophysiology. That's either ischemia, inflammatory, obstruction. So yeah, we gathered some more data. The patient initially experienced the mild shortness of breath and chest pain about 6 years ago, just like I said. Since then, he was diagnosed of pulmonary tuberculosis, was put on treatment, and then he kind of like got better. But he also mentioned that he still had some sort of reduced exercise tolerance. And over the past 2 weeks, it started worsening. Within that 2 weeks, what he mentioned was that he had intermittent chest pain, non-productive cough, occasional wheeze, and episodes of hemoptysis. He also has associated ease fatigue. There is no autopnea, no paroxysmal nocturnal dyspnea, no leg swellings, no weight loss, no night sweats or fevers. Other review of symptoms, there's no polyuria, there's no polydipsia, no polyphagia, no headaches, no dizziness, no abdominal pain, no diarrhea, no vomiting, no dysuria, or symptoms of anemia. So like I said, in his past medical history, he was treated for pulmonary tuberculosis, but he's also a known hypertensive. Also was diagnosed 6 years ago, and he was on regular medications. The TB was treated with the direct observed therapy with a standard HRZ and then HR regimen. But he mentioned that there was initial incomplete response, so he required another full anti-TB medication, after which he was declared cured. There's no history of diabetes, no asthma, no stroke or surgeries. The direct history currently is the antihypertensive medications. He hasn't taken any herbal preparations, and there are no drug allergies. Family history, there's no significant history of hypertension, no family history of asthma or sickle cell disease. He's a retired civil servant. He denies smoking. He doesn't have any reports of history of heavy alcohol use, except occasional use during festive seasons. And then on examination, he is an elderly man, not in any acute distress at the time we saw him. He was afebrile, he was anicteric, not pale, and he was fairly hydrated. There were no bipedal edema. His vital signs, temperature was 36.6. Heart rate was 90 beats per minute. It was regular. His initial BP recorded was 191110. And then when we repeated, it was 187109. Respiratory rate was 20. And when he moves a little bit about and we counted, it rose to 26 to 28. SpO2 at rest on room air was 96%. Cardio exams, apex beat was at the fifth intercostal space. The first and second heart sounds were heard. There were no murmurs or added sounds. Respiratory exams, there was reduced chest expansion on the left. There was dorsal percussion. Breath sounds were markedly reduced on the left, upper and middle zones. There were bronchial breath sounds throughout. The right side was somehow clear, but the bronchial breath sounds were throughout the entire chest. And then there were no abnormalities detected in the abdomen. He was alert and oriented, and there were no focal deficits. I will stop here and then hear your thoughts on that.
Absolutely expertly presented a number of data points there, Eugene. Wonderful presentation. Really a lot to unpack here. But while you were going through this history, I was thinking about conditions that can cause trouble for this patient over a long period of time. So it isn't something that just suddenly just happens acutely, like ACS. The things that we commonly are trained for. I do a lot of rapid response scenarios with residents. We talk about things suddenly happening, sudden collapse, sudden syncope, sudden chest pain, sudden shortness of breath, emergency, where emergencies have to be implemented. But here, this patient's been suffering with this for a long time. And then there's a lot of different things happening, like this TB. And it's very easy to neglect this and sort of put it on the back burner. But I'm going to do something different. I'm going to entertain this because I we had a morning report yesterday, and I did commit this error of looking over history that seemed to be negligible, and it actually played quite a part in this patient's condition. So this pulmonary TB, yes, it can be nagging. It could cause repercussions. The patient got treated, but at this point, I don't know. It definitely in the investigations, labs and imaging. I think imaging will pay dividends to see if there's anything residual in the lungs, but it has my attention. Also, the therapies, could they do something to the lungs? You have to think about certain conditions in the lungs that can be sort of they ramp up very slowly and are very insidious, and things like IPF could happen, and it doesn't usually get you initially, but it does build up. So that's something that comes to mind. Some cardiac conditions may be gradual, probably not a pericardial effusion, anything like that. Pleural effusions, likely not, because you do feel the impact quite within maybe months. You do feel the impact of that pleural effusion as it starts causing atelectasis. So those kind of conditions less likely, but I'm worried about the lung parenchyma. Looking at the vital signs, the SAT is fine, although patients will have the symptom of not feeling like they're getting enough oxygen. They're working hard to breathe. Respiratory rate is 20, so it's the upper limit of, it's not 16, but 20. So above 20, I get very nervous, but that patient's right at that juncture where they are working to breathe, and they are able to maintain SATs. And then there's this pulmonary exam, which is very nicely described by you: reduced chest expansion on the left and delta percussion over the left. So the left is the area where I'm very, very interested in, and definitely imaging will be required at this point, looking at the left part of the lung. So then you have to wonder about what will cause reduced chest expansion and also percussion. So percussion, when you percuss, a lot of times dullness could be intraparenchymal infiltration, or it could be pleural effusion, those kind of things. So there's something occupying lung volume, because usually when you percuss, you're going to have a certain tone. When that tone is heightened, there could be too much air. And if it's dull, there's substance occupying, which could be fluid, it could be cellular, it could be blood, it could be any number of things. So I'm very interested that the lung is probably the center of gravity. This might help us to make some progress in trying to identify what's going on with this patient. A lot of things, if you flip back to the review systems, no orthopnea, PND, so those have a very high likelihood ratio for heart failure. So heart failure kind of is lower on my list of possibilities, but you can also already eliminate that because these findings usually have a very high likelihood ratio for heart failure. And there's no weight loss, no night sweat. So infection at this point, less likely, although somebody in the chat did put up what is the patient's immune status. If they are immunocompromised, we don't have any hint of immunocompromised status, but sometimes you won't have that inflammatory response. You won't have the fever, you don't have the white count, and so on. But hemoptysis, yeah, I was kind of glancing over because there's a lot here. So fatigue is non-specific. Patient is going to be fatigued if you can't breathe and if there's inflammation on board. But hemoptysis is interesting. Why would you have hemoptysis? So pairing this with this lung findings, there's going to be something within the lung where there's erosion of maybe the mucosa, submucosa, because the vessel, the plexus of vessels are just lying below the mucosa. So this blood is probably emanating from sort of some structural damage, maybe bronchiectasis. Bronchiectasis can be primary, can be secondary to long-standing issues like pulmonary TB, maybe. Pulmonary TB itself could cause hemoptysis as well. So this is very intriguing. Can we pair it with that, or could this be lung cancer as well? I mean, we talked about dullness, reduced expansion. Maybe there's endobronchial tumor, and then there's also the pulmonary air, the pulmonary bronchi on the left side is not able to fill. So you could have some atelectasis as well on that side. So that's why that lung expansion is reduced. So I'm trying to put all this together, but I think imaging really will help us. Yes, labs, if there's leukocytosis, yes, maybe there's inflammation/infection there as well. But I'm very, very curious if the images will help us to identify what's going on. I'm just scanning the chat to see. Deborah brings up something very interesting. Maybe ask the patient to walk to check the saturation. Actually, that's a very good, I call it the walking stress test. I had a patient that looked very comfortable in bed and they came in with asthma exacerbation. I asked them to walk and they dropped their sats. So I was like, you cannot go home. You're not dischargeable at this point. So a walking respiratory stress test is very important as well. And Lyra mentions empyema. Rahul asks about the oral cavity findings. Rahul, are you able to unmute, and what are you thinking with the oral cavity?
Hello, Dr. Ravi. Yeah, can you hear me?
Yeah, go ahead.
Yeah, so wonderful discussion. I was just wondering, this has been going on from the 6 weeks, six years, but it has got worsened in the last 2 years. And I think he has history of tuberculosis. I'm just wondering, what about his oral cavity, for example? If there is a poor oral hygiene, there is a risk of in the background of alcohol, there is a risk of aspiration to like possible empyema. So that was my thought process. Yeah, maybe given the reduced chest expansion, it could be likely from the something external to the lung tissue, likely pleural effusion, or as you mentioned, it could be of any intra lung parenchymal problem, like it could be any background tuberculosis or any atelectasis. Yeah, so that was my thought process. Definitely, I guess imaging is going to help us in localizing and in identifying where exactly is the pathology going on.
Wonderful thoughts, Rahul. Just talking to you, it triggered thoughts like the TB again, circumnavigating the area of the TB. And what can happen, even though active TB in the chat, people talking about it, it's been a long time since a patient has TB. Could this be recurrence of the TB? The other thing that could happen is TB can cause a lot of structural changes in the lung. We had a patient with a case of TB with cavity, and the cavity was then taken up, or the residence of the cavity was taken up by a fungal infection. So we have to think about bronchiectasis that can cause hemoptysis, cavities, which could be superimposed, infected by any number of different things, inflammation, friable airways because of TB. So any number of these different things could cause hemoptysis, and also this respiratory condition. Anything acute on chronic. So yes, you could have this background. Could something like PE happen on top of this? Could there be lung carcinoma with metastasis? But 6 years is a long time. But there can be repeated cycles of inflammation in certain areas, which can become dysplastic and cause malignancy. You just need mutation to happen. So these things can happen, although less likely, I think, in this patient. And then you have to worry about, we haven't had the labs yet, but any vascular issues, vasculitis maybe. So GPA, you have to worry about good pastures, AVMs, think of that nature, pulmonary hypertension, could that have something to play with? I mean, it could have some involvement in this case. I'm not sure, but the labs will definitely help make progress with this as well. Okay, back to you, Eugene.
Yeah, very, very great discussion, amazing thoughts. So I'll give us some labs. We did a complete blood count. The white cells was 6.24. The hemoglobin was 15.6. Platelets was 171. And there were no any abnormal differential counts in the complete blood count. Then we just repeated the gene aspect with sputum. And it was negative for microbacterial tuberculosis. Also, sputum acid-fast bacillus was negative. Then we did HIV 1 and 2 just to see if this patient was immunocompromised. It was non-reactive. We also did the basic metabolic profile, including renal function test, liver function test. They were all normal. They were all within normal limits, including electrolytes. And then we did BNP because we're also wondering if this could be signs of some kind of worsening heart condition. So we did a BNP, was mild elevated at 180. Then we did a chest X-ray. For the chest X-ray, I don't know if Sam can upload it. If not, I will do it here from my end. I want to show us the chest X-ray so that we can take it from there.
I would have to unshare the screen and then share what you sent me. I can do that real quick.
Okay.
Yeah, give me just one moment. All right, just don't look at, I'll try not to show anything below this. I don't want to give any spoilers, but this is the X-ray. Can everyone see this?
Yeah.
Okay.
Anybody? I see Ala has a emoji there. Anybody want to take a stab at reading this? Such a great finding. Lyra, are you able to unmute and maybe describe what you're seeing?
Yeah, for sure. Hi, Dr. Ravi. Thanks for
Hi.
having the session.
Thank you.
Yeah, just reflexively, I looked at trachea and it was so deviated to the left. And like from the physical exam, I thought there was gonna be volume up on the left, given the dullness and percussion. I was thinking of pleural effusion, but it's actually volume down. And it's all pulling the trachea to the left side. So yeah.
Absolutely, absolutely. So wonderful, wonderful description. Marlet also commented on this. So tracheala as well. Hans, wonderful reading of the X-rays. So you have to start thinking, what will cause an entire shift of structures to the ipsilateral side? So the pathology is on the left side. We initially hypothesized the left side is likely what is the answer lies on the left side of the lung, right? So there was dullness, there was volume loss, and what can cause volume loss of the lung? Atelectasis is one, right? Or lung collapse, maybe pneumothorax. You may look at the right side and think, hey, this could be a pneumothorax, but we are seeing lung tissue or lung markings on the right side there. So this is a tension pneumothorax, which could push the mediastinum to the left side. And there's also one thing that would be missing if this was a tension pneumothorax. The patient would be hemodynamically unstable. So what you're seeing on the left side is atelectasis, and you can imagine when the lung collapses, and the lung can collapse, there's three mechanisms of atelectasis. One is if the bronchi is obstructed, so if there's an endobronchial lesion. Second, it could be an extrabronchial lesion, so something pushing the bronchi and collapsing it. Third thing could be microatelectasis. So if you have loss of surfactant, then the alveoli loses that surface tension and will collapse and will cause this atelectatic-like image that you see in this X-ray. Wonderful image, by the way, Eugene. So the entire mediastinum, the trachea is shifted, and you also will see the hemidiaphragm lift up if you could see it, but here we're also not seeing it. So here you have massive atelectasis. That explains why this patient is having these symptoms. In a patient with pre-existing respiratory disease, you may see them become very symptomatic. This patient is just teetering at the edge, is compensating, and at this point isn't showing signs of decompensation. But some patients, it can become very symptomatic and need immediate investigation, maybe bronchoscopy to relieve an obstruction, bronchial stent if there's a mucus plug, removal of a mucus plug, and all of those interventions to help rescue the patient. So at this point, wonderful X-ray. What will be the next step? I think let's do breakout rooms. I want you to go into breakout rooms and think about what would you do next, and then secondly. Okay, thank you for muting. So I want you to go in breakout rooms. What are you going to do next? And then think about what kind of things are you worried about in this patient causing massive atelectasis of the left side. So I'm going to stop. Okay, welcome back everybody from your breakout rooms. I'm going to just call on a few rooms to see if they had any opinion where to go with interventions or testing, and what do you think is going on. So I'll call on room 1, Deborah and Hans. Would any of you like to open and mute your mic and discuss?
Yeah, hey Ravi. I think Hans had really great thoughts. Do you want to share, Hans?
Yes, but they didn't give us a diagnosis or anything. I was just thinking about if this white area in the left lung is some fluid. Our first question is, where could it come from? It must be fluid which built up in the lungs and exerted enough pressure to pull the trachea to the right. So either in the lung, or is it in the pleural cavity, which then pushes the lung to the right. And the idea was, where could it come from and what kind of fluid is it? Is it blood or is it a water pus? And where does it come from? And in order to get an idea where it might come from, maybe a CT scan. And Deborah also suggested a bronchoscopy to get a sample of the fluid.
Absolutely wonderful. Yeah, I think this is one of the scenarios where CT really will be helpful to determine or really get a three-dimensional idea of what's going on in the lung. And next I'll call on room 3. Austin was there. Vinny, any of you would like to unmute, maybe share your views? Okay, if not.
Yeah, absolutely.
Okay,
so
go ahead. Hey, Vinny.
Yeah, Austin was telling us about like what can be causing the atelectasis. So it could be like an external compression or an endobronchial issue. And we discussed it also things that would be creating a dead space between the both pleuras, and it could also be just a malignancy from the pleura. That will be more rare from the perspective of the patient having TB, but just a fibrosis of the lung per se from a long-standing history of TB could be pulling the lung and generating the atelectasis also. And that's interesting because there's a 6 long year history, and that would be make me think to think about more in fibrosis. But it is indeed prudent to go for an invasive test and the imaging to see if this is an external or endobronchial issue, the etiology of the atelectasis.
Yeah, I just love that thought about scarring causing that, what we call contraction. I mentioned there were 3, I remember, but there's actually more. There's 5 causes of atelectasis, one of which is contraction atelectasis due to circuitrization of the lung. And remember I said to consider TB and its after effects. One of them could also be what you mentioned, Vinny and Austin, is fibrosis, and that fibrosis could cause traction and causing collapse and distortion of the lung. So that may be very valid at this point. I think that's high in the running for a diagnosis. Thank you. And lastly, I'll call on Lyra. Lyra, mentioned in the chat the room was on fire. Lyra, would you care to share what was discussed in your room?
Yeah, I guess we don't have much to amazing Venus thoughts. We were talking just along the same lines, what can cause atelectasis, and we were also raising the possibility of history of tuberculosis in this patient, potentially explaining this. But interesting that the worsening in the last 2 weeks couldn't be explained by the old condition, so there's definitely something interesting going on.
Absolutely. And Rahul, you mentioned something in the chat. I'll call back on you since you have your camera on. What could you share what you were mentioning in the chat?
Yeah, I mean, this patient has history of tuberculosis, which was not completely resolved. And TB is one of the leading, at least in the developing countries, it could cause exudative pleural effusion. I'm not sure whether patient had a regular follow-up in the past, and if there is any kind of pleural effusion which was left untreated, all exudative proteinaceous material, they're gonna get more of bring a lot of chronic inflammation. They cause fibrosis, and they're gonna trap the lung inside. That would also result in this kind of atelectasis picture. And the second thing would be, is there any lung malignancy, as Vinny was pointing out, any endobronchial malignancy, which is causing the same, where it's causing the mucus plug? Because I've seen one patient where there's strong mucus plug, completely collapsed lung in a 97-year-old female. And definitely he's 65, definitely probably good imaging scan, then followed by the endobronchial bronchoscopy just to see what's going on. And the other thing would be bronchiectasis. So these three things in the background of tuberculosis. I think these three things will be my top differentials.
Yeah, I think it's very important not to overlook the TB. Remember, I said like very easy. There's so much here to unpack that you could easily ignore the TB. But I think TB and its ramifications, its sequelae that it's so many that we talked about, definitely could have something to do with this patient's presentation. It was interesting. 6 years. That's an awful amount of time. And this patient really isn't sick up until we saw the image, right? The image doesn't fit the patient. The patient, actually, the way Eugene is describing, is having all these different symptoms, but not terribly symptomatic. There are a lot of non-specific symptoms, though, but it's been compensating with it. John just joined, and I'll bring John in. You got to listen to some of the case. Any thoughts before we go to the next aliquot?
Yeah, thanks. That's a nice. It was a nice summary hearing everyone's points from the breakout room. Sorry for I get caught in traffic and missed the first half of the report. But and kind of in summary, seems like this 65-year-old gentleman who had a prior tuberculosis. Perhaps some of the details not certain, but was treated with some long-standing chronic shortness of breath that's subacutely worsening with the X-ray, with kind of the whiteout of the left side there. And some folks have highlighted that you see if you're considering, is this something taking up mass or is it a collapse of the lung? Try to look to see if they're, what direction the airway, and look, if anything, it looks like the airway is a little bit over towards the left side, suggesting some volume loss as over the other options. So how am I putting this together with like a chronic shortness of breath into something more acute? So I'm going to kind of tackle them separately a little bit. The chronic, with the background of treated TB, it's one of those things that's so difficult to fully exonerate without more invasive testing. If it were incompletely or resistant to TB, I might have expected the person to be more sick and more profound systemic symptoms than it seems were described. But otherwise, what could contribute to this chronic shortness of breath? Considering like there's a tobacco use history. So if this is atelectasis, it makes me worry about something obstructing the airway. And in somebody with a chronic shortness of breath, tobacco use history, and endobronchial malignancy would be highly concerning, perhaps contributing to shortness of breath. And then once it reached a critical threshold, then you have large atelectasis, suddenly worsening shortness of breath, at risk for post-obstructive infections, although we don't have a fingerprint of acute inflammation in the moment. And I agree with some, the next steps to better define the space. A CT of the chest would be helpful, and I think a bronchoscopy could be both therapeutic and diagnostic by means of getting a better sample for microbiology and pathology, and potentially, if depending on what's causing the obstruction, sometimes if an obstruction is caused by something as simple as a mucus plug or something, they may be able to do a therapeutic treatment and help open up the lung as well. Yeah, I think with that, I'll turn it over. Maybe we can get the next aliquot.
All right, back to you, Eugene. I'm anticipating a CAT scan.
Yeah, I wish I actually had the image or the video for us, but I don't have that for us. But yes, the thoughts were on fire. The reports from the X-ray showed left lung atelectasis, lots of mucus blocks. And we did ECG, did echo, just to make sure that we are not missing any heart issues. ECG was normal, echo had preserved. LV systolic function, no significant valvular abnormalities. Then we did a CT chest, which confirmed a complete collapse of the left lung with a mediastinal shift. Unfortunately, we didn't see any obstructing or endobronchial lesions. And where I work, we don't have a center that we can go on and do bronchoscopy or some form of advanced medicine. So we had to refer this patient. So at that moment, our thought process was that could this be as a result of scarring? So I saw your mnemonic, so maybe this was as a result of, I think that this would be more of the scarring to be as a cause of the atelectasis. But my attendants didn't think that made enough sense to cause this particular level of lung collapse. So we followed up on this case. We did endobronchial biopsy, just as was requested, which had bronchoscopic, which had a stratified squamous epithelium with nest of atypical squamous cells. And we also had keratin pearls present. There was moderate to severe nuclear polymorphism, prominent nucleoli, and frequent mitosis. And they didn't see any active TB or no evidence of granulomas. The immunohistochemistry on this was strong nuclear positivity for P40. So that supported a squamous cell carcinoma. And so the final impression was left lung atelectasis. Initially, we said likely post-tuberculous structural lung disease. That was complicated by the bronchogenic carcinoma. We also added the long-standing hypertension because this patient was newly diagnosed with was diagnosed with new hypertension. And I want to pause here for us to unpack, because if we are looking at the history, we are not seeing any significant risk factors for this patient developing a squamous cell carcinoma. So I will want to hear our thoughts, and then I will do a little bit, maybe just about 1 to 2 minutes of teaching on what I read about the link between long-standing chronic inflammation, especially pulmonary tuberculosis, with squamous cell carcinoma. So I'll just pause here and then listen to our thoughts.
Yeah, I think early on we kind of hypothesized, right? Repeated lung inflammation, destruction, cell turnover. There is a potential for a cell to break away and become dysplastic, metaplastic, and induce malignancy in this case. So just by this biopsy, squamous cells have no business in the lining of the airway. What do you usually have? You have columnar epithelium in the airway, and this just tells you that there's been marked inflammation, cellular destruction, maybe TB, maybe repeated infections, and then over a period of time, this has then turned the course over to squamous metaplasia in the lining of the airway, and now squamous cell lung carcinoma. So, yeah, I think this explains why this has been a gradual process, right? We were thinking about what causes like 6 years of symptoms, and 6 years, maybe this was not all of this. This presentation was not the malignancy, but it was the build up to the malignancy, which then just hurried up the presentation of the patient to the hospital. to be seen. And he's got all the hallmarks of a squamous metaplasia. He's got the shortness of breath. He's got the hemoptysis and so on. So a very interesting case. And you have to wonder, like, with this atelectasis happened secondary to this buildup. But for 6 years, I was wondering, like, that I don't have a good handle on why he was so symptomatic. John, any thoughts regarding like this biopsy that we have?
Yeah, I agree. I'd like to perhaps the best as our folks have already said, the best way I can kind of find is just perhaps chronic inflammation and perhaps alcohol use being risk factors. And the chronic side makes sense. I'm still like didn't have quite the full connect for why the patient all of a sudden had multiple mucus plugs and full atelectasis if there wasn't an obstructing lesion or severe scarring seen on imaging or bronchoscopy. So a little uncertain, like why the mucus, why they're having this trouble pretty acutely. But it's not perhaps the timeline does make sense with the chronic into the acute, but the connecting factor is still a slight puzzle to me. Anyone else have any thoughts?
If not, we can turn it over to Eugene for his teaching thoughts. Go ahead, Eugene.
So I'm just going to tie this case to last week's discussion. I mean, last week the case was on amyloidosis and then Castleman disease when I discussed with Ravi. And yeah, I had not seen a lot of amyloidosis and seen what chronic inflammation can do. So it just took me into a cascade of just reading about these topics. So it's just a state of chronic inflammation with the release of interleukin-6, necrotic factor alpha that has just, so I did a study and I saw that there are actually about 3 population-based studies, some in South Korea, and even a recent systematic review that has linked chronic tuberculosis, that's pulmonary tuberculosis, with squamous cell carcinoma. So you have one study that was done amongst 5,000 people, and then the incidence rate ratio was about 2.04. So you have so when they did the cohort study, they saw about 444 people with squamous cell carcinoma who were previously having pulmonary tuberculosis. And the little pathophysiology is just that with the chronic inflammation, there's the activation of the STAT3 pathway, which which induces angiogenesis, proliferation, and these are actually, they invade apoptosis. So what happens is that patients become prone to dysplastic changes and then metaplasia in normal cells, and then that leads to the abnormal proliferation of cells and then a cancerous event. So the other thing too that I think John raised was that possibly there could be that the previous use of, but that was moderate, that's the alcohol use, could also predispose this patient to squamous cell carcinoma. And the link between why this patient came acutely, and so like if we saw in the examination findings, and someone also pointed out that we should have done we should have allowed the patient to exert and then check the SpO2, but it was a respiratory rate that came out to me. So this patient was allowed to just walk about a bit in the examination room, and we noticed that the respiratory rate increased. So it was just how amazing the body was compensating with just the right lung. So in his normal rest state, he was fine. But when he exerts himself, that is when he tends to have his symptoms. So it's just how amazing just one right lung. So about this case, it was just fascinating to me the way the body could compensate the state of chronic inflammation over a period of 6 years, and how interleukin-6, human necrotic factor, can just induce other pathways that can lead to the proliferation of abnormal cells and then a cancerous state. So just like in the state of amyloidosis, which we learned last week, where interleukin 6 will lead to secondary amyloidosis, that's A amyloidosis, and then just deposits of misfolded proteins in different tissues. This time you can also have abnormal proliferation of cells that could lead to a cancerous event. So the next things that were done for this patient in the tertiary facility was that they did a PET scan. They realized it was resectable, and this patient underwent surgery. And I've not yet followed up to know the sequence of events, but that is how far I was able to gather with this case. And I'm excited that I was able to bring it, and a lot of rich pearls that I've also added to my own learning. Thank you.
Wow, amazing case, Eugene. I'm just absolutely enthralled by this, especially the duration that the patient had these symptoms, and then again, the cellular chapter of our pathology textbook is very important because this right here, you mentioned inflammation and the change in the cell structure from normalcy to malignancy is just amazing. And Sebastian put in the chat just the central location of SCC is why the patient was having airflow turbulence, obstruction, atelectasis, and all of that. So amazing case. You really did challenge us today, and I really like the X-ray. Thank you for bringing the X-ray. I was not anticipating this, but lots and lots of teaching in this case. I appreciate you for putting it together. Any reflections, John?
Yeah, great case. Thanks so much for sharing, and appreciate everyone's thoughts from the breakout room. I don't think I have too much more to add on top of the great discussion you've already done. So with that said, we'll now turn mic over.
All right, over to Vale for teaching points.
Yeah, thank you for this great case, Eugene, and brilliant discussion. So we began with the chief concern of exceptional dyspnea and chest pain, and Ravi broke down the system approach to this dual chief concern, kind of narrowing down to hearts versus lungs. And then with the exertional component, we were wondering if this is a problem with the pump or the oxygenation or the vessels themselves on the legs that would lead to exertional or problems ambulating. So a teaching point here was to always look at the legs for any changes that could suggest a vessel obstruction there. Then the acute and chronic presentation of this patient with a pathological history of TB made us wonder if it was a recurrence of a past disease, a superimposed infection, or something as completely and just the past medical history as a red herring. Then the physical exam gave us quite a semiological sign of dullness to percussion, and we were wondering if this dullness could represent an increase of water, of cells themselves, or of blood. And Deborah gave us a great teaching point on the chat that we should never forget to check the O2 saturation and respiratory effort with walking, just to make sure that this patient does not have exertional dyspnea, even though they may have normal saturation at rest. Then we broke down the lung volume loss that we saw on the X-ray. This could be caused by a tension pneumothorax, but also from a massive atelectasis. And Ravi taught us the a mnemonic for mechanisms of atelectasis called COCAR. The C stands for compression, then obstruction, contraction, adhesion, and then replacement. And finally, Eugene gave us a great teaching point, highlighting that chronic inflammation could be a risk factor or could lead to lung malignancy because of the progressive cell changes and inflammation on the cells on the lungs. So yeah, thank you so much for this case.
Oh wow, Vale, those are high yield teaching points. You summarized it wonderfully. So very easy to follow and very easy to remember. So thank you, expert level teaching points. All right, thank you, Eugene, again for a great case. Thank you, Samantha, for scribing. Without all of you, we couldn't do this. Thank you, everybody, for attending, and be back this afternoon for Rheumatology VMR. Take care. Have a good afternoon. Bye.